And welcome to the CCG governing body meeting for November. This has been live streamed over the Zoom platform and onto YouTube, so thank you very much for those that are joining to view this. Just going to the agenda in a minute, but I do notice that we had a question that had come in from September's meeting, so I was wondering whether we could pick that up with one of the exec colleagues, if that's okay. So that question was Kath Bryers on behalf of the local Royal Osteoporosis Society committee, and they ask, we would appreciate any information on the trialling of an IV for osteoporosis patients in Easingwold and an update on DEXA scans availability in York. So I don't know whether one of my exec colleagues could answer that.
I think it probably falls into my portfolio, Nigel. We've provided a written statement. I'll just pull that up. So the DEXA situation is that we're working through the backlog at the Nuffield. This is a slow process due to the IPC requirements, and there are 900 referrals on the backlog. So we are working and sending out comms to GPs on behalf of the Nuffield, and there's a fuller explanation in the written response from Annette that can be published with the notes. So just moving on to the IV trial, again, there's a detailed written response. That work continues. It's working well. It's still in a small geographical patch, and we continue to work with SHA on reviewing the expansion of that, but within the confines of the SHA PCN area. So that's our north locality. So there's a fuller explanation in response to the questionnaire, but hopefully that's covered the main points.
Yeah, great. Thanks, Steph. We'll put that response in the minutes. Thank you very much. Okay, so just moving into the main body of the agenda. Apologies for absence. I know that Phil Goatley is unable to be with us at the moment. He might be able to join us a bit later on. And Andrew Moriarty is attending for the LMC. So thank you, Andrew, for coming to attend. Just another couple of things around this is that we might have to change the order of the agenda around a little bit, but I will explain that as we go along. Any declaration of members' interests that aren't already declared, and as we go through, please let me know. I'm going to move on straight into the minutes of the meeting from the 3rd of September that was chaired by Phil Goatley. And if everybody's all right with those, and if there's no clarifications, then we'll move on to sign those and go to the minutes, the matters arising, if that's all right, and the actions. Is that okay? Yeah, that's great. So the matters arising, I see, actually are going to come back into this body of this agenda. So item 9 is going to cover the staff risk assessment, is going to be the cover BAME, and also we do have the learning disabilities and SMI health checks coming back into this as well. Just another item on this agenda is that Steve Moss will attend, or is attending, for the counter fraud guidance for primary care. Okay, so I'm going to move on further into the agenda, if that's okay, and that's to Phil for the accountable officer update.
Thank you, Nigel. Morning, everybody. I'll work through my my report without necessarily referencing to each paragraph, but I will try and cover all of the main themes that are contained in there, starting with the financial position, which Simon Bell will provide more information on later. But for this governing body, I would like you to be reassured that through our Finance and Performance Committee on a monthly basis, we have continued to assess the risks to the CCG of the changing position within our health system, affected primarily by COVID, and the new arrangements that we have for managing financial risk, both nationally, regionally and locally. More on that from Simon in due course, but I think through David Booker's leadership in the Finance Committee, we've maintained our approach in terms of good financial governance. So I would like the governing body to be reassured in that respect. Quite a lot of information or reference in the report, of course, to COVID. Our focus has continued to be on supporting primary care and our member practices, and in particular, working with the care homes across the Vale of York. We're now well established in our arrangements working across North Yorkshire and York as a system. So we have pretty well established silver and gold arrangements that are now taking a regular weekly overview of all of the operational issues that COVID is creating for us. My sense is, and the feedback that I receive from silver, that is working well. Relationships are strong, partners are collaborating together, supporting each other. The gold meeting that we have on a weekly basis, equally the same. So coming out of our COVID period, first wave, we do have, I think, solid and robust new system arrangements in place, which should position us for going into this autumn and winter and the second wave. Locally in York, we also continue to meet on a weekly basis, looking at predominantly out of hospital services, making sure that we are coordinating across local government, the NHS, and into the third sector to make sure that we all are supporting each other with the issues that continue to arise. As we go into wave 2, we're now starting to think carefully again about discharge from hospital and stepping up arrangements to support that in anticipation of further demand for hospital care. We're equally focused on creating a capacity for testing of residents and for staff, and within York, the university population as well. That's quite a moving picture. The fluidity of that is something that we continue to monitor and try and influence. And going into this next wave, and as we go into the period where university students will move back out of York and back home, we're actively talking about how we can mitigate any risk to increase transmission across York in that respect. And equally now actively talking with our providers about the impact of COVID on the elective procedures that we have submitted plans for and developed plans for with our providers, predominantly York Hospital, over recent months. One other reference in my report is to the protected learning time. As I close now, Nigel, perhaps you and colleagues might just describe what I understand was another very successful but virtual experience. But I'll leave that to others who are better placed to describe that. I'll pause there. Thank you. Happy to take comments and/or questions.
Yeah, thanks, Phil. Helena, I don't know whether you wanted to come in to talk about the protected learning time and explain in a few minutes what it outlined and where you think we the positives and have been?
Yeah, I do. So, at least 300 people tuned in. I know that the numbers are a bit more difficult when you look at the web platform, but I'm aware that in our PCM in particular, a lot of people tuned into the afternoon.
I'm struggling to hear you, Helena. I don't know about anybody else. I don't know whether your microphones.
Have a go. Hang on.
That's better.
Is that better?
Yes, thank you.
I think it's more to do with my signal than it is anything else. A good 300 people tuned in to the learning event. Lots of people in my area.
And the event covered why dementia diagnosis matters, why we have a problem in York with diagnosis, the specific groups that seem to fall through the gaps and don't achieve a diagnosis, and what we can do about it. And the event sought to really, it's a bit of a cliche to say it, but hearts and minds, really gather the hearts and minds of our primary care and community teams into understanding why this is important and why it matters, and to really give them straightforward tools to be able to address it. And I think there has been a decent impact from what we know from individual conversations. What we now need to do is to make sure that that translates into real action that's measurable and fed back. And so I think there needs to be some degree of follow-up in terms of direct feedback to practices about where they are, how they're improving and what they're doing, and that needs to be picked up. But it's a really good start, and I think the feedback was generally really very positive. I know that people were very much welcoming the fact that they were doing something that was not COVID related, because there is a sort of collective exhaustion, and to be able to focus on something that has meaning and relevance during a pandemic, but actually was not directly related to the pandemic, that was welcome.
Great. Thank you very much. And I know that we have been asked for sort of like in the feedback about follow-up sessions, so we will take that on board. And I think that's a good point about measurable outcomes and showing people how things are moving. So that might be something that I don't know whether Denise, you can maybe comment on or want to comment on about how we can support practices with that going forward. That's great. Thank you very much. Was there anything else, either on the protected learning time, the focus on dementia, or in Phil's presentation and report that anybody wanted to highlight? Yeah, Andrew.
Yeah, I just wanted to say I was unable to attend the last PLT actually because I was away, but I just wanted to say it's really commendable that the CCG is sort of prioritising those events. I think they're really useful. And I think the last virtual one I attended was not the worst for it, really. I think it's still a really important thing to be doing.
Great, thank you very much. That's really good feedback, actually, because we are wondering how to keep them fresh and how to keep them different for people. So the thought was for the next one, whether we go more place-based and more PCN-based to allow a local focus. So we're taking everybody's feedback on board around that, but then trying to make sure that we cover the wider bases as well. So that's really good feedback. Thank you. Okay, Julie, did you want to come in?
Yeah, I was lucky enough to attend, and I think the thing was, especially in the chat rooms, it was the energy and the drive and the fact that there's a real can-do attitude, recognising that there's not necessarily huge amounts of money, but working in a different way, as we've been doing anyway with COVID and a lot of the teams, and so it was hugely powerful, and people felt listened to. It was absolutely a pleasure to be part of the day.
Great. Thank you very much. Okay. And anything specifically for Phil in his report? Otherwise, we'll move on. That's fine. Okay. So next one is over to Michelle. Michelle, can I?
Yeah. Can you hear me? Okay.
Yep, we can. Thank you.
Okay. So let me just get the right page. So because we had a governing body workshop in October, this report that you see is a combination of September and October's QPEC reports, really. So we accept that some things might have moved on since governing body have seen some of this. So I'll just pick out a few bits. On page 26, in terms of COVID and the change to commission services and the particular focus on trying to keep the good stuff that we did during COVID alive and running, and using that for transformation of services, the Humber Coast and Vale Clinical Leadership Group, under the chair of Nigel, came up with a set of principles that we should work with to try and solve these knotty issues. And you can see those on page 27. I don't know whether Nigel wants to come in and say anything about it. They've been widely shared, and hope that people will adopt the way in which we work together to solve some of those issues.
Yeah, I can quickly add to that. It's more of sort of a destination or a set of principles that I think actually probably wide enough for people to understand and adopt at different places and different areas of our ICS, but also narrow enough to show that there's a direction of travel. The real issue is now putting a lot of actions behind that, especially when we're dealing with wave 2. But I think in the longer term, this is where we need to be heading. So yeah, thank you.
Thanks, Nigel. In terms of care homes, we continue to support extensively the work at with care homes, and that's expanding all the time. What we are seeing is the cases of COVID are increasing, not so much in the City of York patch, but definitely in North Yorkshire. And we're supporting North Yorkshire County Council as much as we can, as well as North Yorkshire CCG. It's mainly around training and support over infection control principles, and also the learning from any cases and outbreaks that we get. We've got a tool in place now, and what that's telling us is you can really quickly get to the bottom of what some of the issues were. And often it's what happens with staff outside of hospital, and car sharing that's been a particular issue, and also people who work in more than one setting. Has also been some learning from that. What we've tried to do is work really hard with our communities on trying to get a really pragmatic approach to visiting in care homes, completely accepting it can be really devastating not to have visiting and not for having visitors for such a long time. And some care homes have been really innovative in the way that they've allowed visitors in, but it's absolutely not the same as touching and holding your loved ones. So together with North Yorkshire and City of York, we've come up with a set of suggestions which are really good. And then, of course, last night you might know that the government produced a set of guidance for visiting, which we're just working through to see if that makes a difference. Of course, we've gone back down into lockdown, and so the approach that we might have wanted to take with our set of principles might not be able to happen. So that work's happening really quickly so that we can get some further guidance out to people. I can't see anybody's hands while I'm looking at the report, so please shout, Nigel, if there's somebody that wants to ask me something. And the care homes are particularly well embedded in the work of the new discharge guidance, and on the whole being very accepting that they might need to change their way of working to accept people over weekends and accept people who have positive COVID tests but are outside of the 14 days. Because they're not infectious, and just helping them to understand what some of those tests mean. But they're working really hard with us on all of that. Capacity-wise, really stretched. There's not a lot of beds available at the moment, and domiciliary care is a particular pressure for us as a community. Okay, I'll move on. Flu planning, I'm sure, is taking up everybody's time. There's an overview there of what's happening, and of course it's a little bit out of date as we've gone on 2 months since, and of course the numbers have vastly increased, and we know there's been some fantastic programs out there of getting huge numbers of people vaccinated. And of course, the next big show in town is the COVID vaccine work that we need to be concentrating on. And I'll pick that up in the COVID update later on. In terms of mental health, what we have seen during COVID is an increase pretty much across the board, and I know Denise, my colleague, will come in and fill in the gaps of some of this. But crisis have seen an increase in people accessing services, including inpatient admissions, and some of those people, quite a lot of people, have been unknown to services before and having late presentation with psychosis, which is a bit of a worry. Increase in early intervention psychosis, increase in IAPT, and I know that they have increased their face-to-face conversations with clients, but there is a worry, I think, about inequalities, and is that okay for everybody to use that way of working. Dementia we've talked about, and we are going to have a focused QPEC as a standing item agenda on dementia in November, where we'll further explore some of the stuff that was in the PLT, but also how we have a review of the services that we've got and seeing if they're meeting the needs of our communities. Because we are wondering if the variation in dementia rates really suggests that it's a quality and safety issue, potentially. Eating disorders referrals are up significantly with very poorly people, but we are meeting the assessment target. And health checks, we have met the target in Q4, but there is a long way to go in terms of what we would want that to look like. And autism waiting lists are up as well. And of course, schools are back and have been back for half a term as well. So I'll just pause there in case Denise wants to add anything there, or anybody else come in.
Denise, did you want to come in on anything there?
You're on mute, Denise.
I think Michelle's accurately presented as it is, Nigel. There is and it's not just locally, of course, and well recognised nationally, the growth in mental health presentations during this time. Lots of work going on to see about how that can be modelled, lots of flexible, different ways of working. Obviously, 24-hour crisis is now in place, both for children and adults. Looks as if CHUV will be a leading organisation for a resilience hub for the local area as well, to try and build people's well-being again after this. There's certainly some learning in terms of Michelle's perspective that online doesn't suit everybody. It doesn't, but online suits and is preferred by some people as well. And it's quite difficult to understand in advance, if you don't know the individual, which I suppose category the individual falls into. We know from some reviews that CHUV have done into some clients accessing services, they are doing some lessons learned about when do you pick up that people are not accessing care perhaps as you'd want them to, and is that due to it being online, or when do you actually need to do face-to-face? I think people are doing as much as they can, but this is a whole new way of working for everybody. The hospitals are the same, aren't they? And I think it's just about improving communication between primary care, mental health services, the hospital during this time, and people recognising that actually other people might have a view about individuals' risk, and we just need to wrap around those people better from a joined up service perspective.
Great, thank you. I don't know whether there's anything that you wanted to comment on around eating disorders. Then is increased referrals, and then one of the issues that sometimes primary care flag is the lack of monitoring in the community as well. Is this going to be a significant issue going forward if we've got increased referrals, but then also we haven't got that backup into primary care to help?
So the increased referrals during this time are children, Nigel, very significantly children. Not sure why that is. we're, as Michelle says, we're meeting those targets. For adult eating disorders, there is a provider collaborative being built on those across Humber, Coast and Vale. And we're starting to have conversations that as providers start to come together to collaborate about adult eating disorders, please don't forget that there are community services managing people out here. Now, and I've personally had conversations with the lead officer from the ICS around what the issues are in York, that we've already enhanced the service that CHUV are offering to GPs during this time. But actually, it isn't an integrated service. It's separate to what might be the collaborative. So she's taken that on board and is going to keep me in the loop about those developments so that we try and build a whole new pathway rather than a rehash of two separate services, which I think will be important.
Okay. David, did you want to come in, and then Ruth? You're on mute, David. Still on mute, I think. Might be your microphone. Okay. Oh, can you hear? I can't hear you, David, but can others, colleagues? No, it might be your microphone settings. So I'll go to Ruth and then come back to you. Ruth, do you want to come in?
Yeah, can you hear me?
Yep.
Yeah, good. Just a couple of things really. First one is about access and IAPS, because I know IAPS are only providing at the moment on, you know, sort of digital, sort of telephone or video consultations, and I don't know where they've progressed to. I think that's is that a national thing or just a local thing? I don't know if anyone knows, but my understanding is they did plan to do face-to-face, but when I last spoke to IAP, that provision wasn't there. And that just is worrying for certain people who won't look at themselves over a video and won't engage on the telephone. So it's just, I suppose, just making sure that we keep pushing on what their plan is with that. And then the second thing was just picking up on the piece about communication between CHUV and primary care, with these increasingly vulnerable patients. And I know there is work going on. There is work going on in my PCN and other PCNs to try and look at that agenda. And I know that there is a piece of work going on with regard to CHUV and their community health model, and they're trying to get sort of system partners involved in that. But because of the late sort of dates around the events that they've put in with that, one of them's today, I just wanted some assurance that we are having enough of a voice in those conversations, really. And I suppose Denise might be the person to answer that.
Thanks, Ruth. I think your response to them about the lateness of their ask to us to be involved was particularly reflective, really. That it was late notice. It was late notice for everybody, and I know that they have responded saying that they're not going to make decisions based on the back of these meetings, that they are going to come back to us. I keep banging the drum as much as you do, and I know Phil does as well, about actually engagement with primary care at local level rather than organisational, whole organisational level. It's really important that we do that and continue to do that. That at the same time as some of these timelines are coming out from the ICS about how quickly they want things done as well. We understand as well that at the time that they're having conversations with us about the community mental health framework, it may be that that's now not available this year. The ICS are now saying that might need to go to other areas first. So it's a very fast moving piece of work, and the fact that we've got so many people involved, both with the ICS, with North Yorkshire and York, and with TUV and with GPs, I think I'm not sure I can give you the assurance that we're going to be always there. What I need to say is that we just need to keep making that point and making sure that they let us at least know as early as they know that they want us involved. I do believe that there is a willingness. They want us involved for sure. I don't think there's anything deliberate about it, and they certainly want GP voices, and they do want services that reflect local population. I think it's a big organisation and things happen really quickly, and we really just need to start working much more closely with them at PCN level, and I know you're trying to do that, Ruth, and as is Fiona really, and certainly through a contract basis and through all the contract conversations I have, I reiterate that all the time to them.
Thank you. Ruth,
Can I just
did you want to come back
in? Yeah, just really quickly.
And then David and Helena, I think.
Yeah, just I suppose I hear that, Denise. I suppose what I struggle with is bridging that gap between the conversations that you're having sort of higher up, and then the conversations we're having at PCN level, and then there seems to just be this void of not being able to get the right permissions in that middle layer, and not being able to find the right people to start the conversations. And that, I suppose, that was reflected in my frustration that then suddenly they're asking you to attend a meeting with less than a week's notice, which you can't attend. And although I'm sending them out a lot of stuff, there's a real variation in the response that I get. So I don't want to name names, but I wait over a month for responses to things that I've been told we need to push forward really quickly. So trying to build up things like community-based, primary care-based mental health practitioners, which can be, we've got funding coming in through the PCN DES from April. We want to work with them on it because we don't want to destabilize their workforce. And it just stalls all the time. And I just struggle with knowing where to apply that pressure. I'm still finding my way in that world, I suppose, in some ways. So, but I do just worry that somewhere in between that low level stuff and the really high level stuff, it just gets lost.
And I don't, sorry, if I can just answer that, Ruth, I don't know what to suggest. We've got a local senior person doing the right care, right place with you. We've got a shared post with TUV. I think what I'm going to do, if you would help me with this, is just arrange a call with, again, the exec team and the local operations director, just to hear, and I know that you've said it before, but just to hear it again, and I'll be on that call. And if it needs them to identify one person who you can go to, then so be it, or at least answer the questions. I know things are always easier and quicker to do in practice. You can make things happen in practice, which is perhaps not as easy in bigger organisations. But accepting that, it shouldn't take you a month to get an answer. So if you don't mind, I'm very happy to set that up.
Yeah, Simon, did you want to come in on that point?
Yeah, I did. There's not the virtual hand facility on Zoom that there is on Teams, so I went for actual hand, which was novel. Absolutely agree with Denise. Denise and I have been talking to TUV colleagues about exactly this. They are accepting that there's progress that needs to be made. So absolutely, let's involve everybody in the conversations we're having. They're really keen that they are seen as the mental health partner going forward in the medium term for Vale of York residents and population. They've invested a huge amount of money in the Vale, and want to see the benefits of that investment. They absolutely accept that they haven't got everything right. We need to help them craft their response to our governing body questions to some extent. So that offer's there, that offer's been made. So exactly as Denise has said, we just need to involve the right people in the conversations to make sure that feedback's landed and is understood.
Great, thank you. Okay, well, we'll keep close to that and make sure that moves on. David, let's see how you're getting on with your microphone. No, I still can't hear you. Do you want to put something in the chat box? And then we'll pick that up. Now, Helena, you do seem to have been able to raise a virtual hand, so well done. You get a star for your IT skills today. So, do you want to come in?
I'll pick up on the mental health bit first because I realise that's the thread of this conversation, but I just wanted to mention flu as well. So in terms of mental health, I wanted to ask the governing body really, and this is for perhaps the people who are less close to it than let's say Denise and Ruth, how assured are we that things like the severe mental illness health checks and learning disabilities annual health checks are happening? Because I think there's a data gap, and I'm concerned that the reporting is too retrospective, too slow and too late to be able to establish any kind of fast trajectory of improvement. But I'm also aware that PCNs are not receiving the data on SMIs in that breakdown of who's doing what and which bullet points have been done for the SMI checks. I'm aware that people do not have access to that data. Those searches are not available in EMIS in the way that QOF searches are. They could be made, they could be done, but they haven't been done. And that data is not owned by either practices or PCNs. It's owned by the CCG, and when it comes, it's more than 2 months out of date, covering a period that's 3 months wide, which we know in this year isn't sufficient. So I would raise the concern. I don't think this governing body has the information to be able to say whether or not we're making progress, and therefore whether or not we need to challenge what's happening at the moment to make progress. The same is true of learning disabilities annual health checks, and I realise that there are plans in place to address that. But again, the data gap with learning disabilities annual health check is going to mean that anything we do is so retrospective that it's very hard to critique or challenge or evaluate whether progress is being made and to share good progress quickly. This rapid cycle change is not happening.
Thanks, Helena. So will radar help with that?
No. No, it won't. So radar has got some helpful data on there, but effectively what you need is live practice data and searches that are produced in a timely fashion, and that information is all there. It just needs to be created, and I know how to do it, but it isn't being done, and I can't do that for the CCG. I can't even do that for a PCN. So we need to address that, because if practices don't know, then practices will not improve. And there are some simple things that could be done. We're relying on the CCG being the owner of the data, and that's not working because that's not driving the change. And it's just a simple thing to do with measurement for improvement that I think we're not seeing.
Okay, Simon, did you want to come in on that?
Yeah, I mean, I agree, but in some cases it's not for want of trying. We've had data sharing agreements out there with practices for a long time, and some practices just don't want to or haven't had the time and space to sign them. So I agree with Helena, but we could do with a bit of push from the practice perspective for the data sharing agreements we've got out there and have requested and that haven't come back. We could really do with a bit of a shove to get them over the line.
I hear what you're saying, but I've seen the data that practices have not had shared with them. I've seen them as a governing body member, and PCNs have not had shared with them, that does include the practice level data that we need. So I'm not convinced that this is a lack of data. I think it's being held in the wrong place and not being shared with the right people and not being produced on a regular enough basis. I'm sure there's contributions from all sides, but these things are remediable. I mean, if we can produce the data for how many people are having a steroid injection in practices and make sure that they're paid, then and practices are very motivated to do that because they're getting paid, then I think we should be able to do a timely, data share on this too.
Mm. Yeah, thank you.
I wanted to raise the flu point. Just then I'll be quiet. I wanted to ask a question, and again, this is for the governing body, and I'm not trying to be specific to my area in this. I think it's really clear that some really positive innovation has gone on this year, and practices and PCNs and have really upped their game in terms of meeting this challenge of delivering a flu campaign. And I think the innovation in the centre has been really positive. My question for the governing body, and again, this is to anybody really, is to say, how assured are we that the flu campaign, the offsets outside of the city, have been adequately funded to prevent an impact on the quality and provision in primary care? And the reason for asking that is that I think what's happened in the city is commendable, and the driving force behind that, as it says in the minutes, has been to make sure that the capacity is not affected in primary care and that the service is both convenient and really positive and widely available. How sure are we then that outside in the Vale areas that the same is true, and what offsets in terms of funding has been provided to ensure that health inequalities are not widened? Because mass vaccination centres do not work for people who live at a distance from the city. So it's a question to open up, really.
Yeah, great. Thank you. And whilst we wait for maybe people to come back in on that, David has put his question in the or his comment in the chat box, and also Chris, you've put in the chat box that you'd be happy to pick up something about the data sharing agreement, and I don't know whether that's something that Andrew Moriarty as well could pick up with you as well. So do we, Michelle, do you want to come back in on any of Helena's points, or is there anybody else specifically?
If the question is about the funding, then no, I'm the wrong person, except because Steph's got her hand up ready to help you answer that one.
Okay.
Steph,
did you want to come in?
So we have had some money identified from NHS England, but that came after all the fantastic work that's already happened by our practices. So the data is showing that Vale practices as well as central practices have done what they always do, which is cracked on and seen their patients, been innovative, been proactive, and pushed forward on the ask for the early cohort. Limiting factors most recently have been the availability of some vaccines. So that's the first point I'd say. The money identified has come in retrospectively, and we're going through an exercise of identifying how we can support all of our practices within and without that allocation. And the limiting factor to that is the very narrow definitions that NHS England have given us about what we can reimburse practices for. But as a CCG, there's no intention to disadvantage central versus rural practices in the allocation of that reimbursement based on the definitions that NHS England have given us.
Thanks, Steph. Helena, I'll let Ruth come in. What would you want?
I think I'm seeking assurance that the CCG makes sure that, where funding is directly funding a service, in this example in the city, which is fabulous, that the emphasis was on protecting practices, making sure they don't fall over, ensuring capacity and so on. that actually that emphasis on protecting practices and ensuring capacity still needs to exist outside of the city when there isn't the option of a mass vaccination site. And we need to acknowledge that where practices have prioritised flu vaccinations in-house in their small practices away from the centre, that there is a knock-on effect on routine care and other provision, and a reduction in provision to be able to provide that vaccine push. The trouble is that you can't, that's not a separate service that can be funded in a way that is so easy to describe in the way that that's happened in the city. So I think it's commendable what's happened in the city, but we need to ensure that people who live in rural and isolated areas, people who live in deprived areas away from the city, people who don't have transport to be able to access a drive-through clinic, that actually there is funding given to practices to offset that. And I understand the difficulties from NHS England that Steph's highlighted, but the challenge for this CCG is not to allow the health inequalities to widen. So we need to make sure that we support those practices who are going to find that really hard to define, that activity, and hard to report back the financial envelope for the flu campaign, that actually this is about ensuring that their practices do still have the available capacity that they need to do the other routine care that they have to provide. Does this make sense? It
makes sense. I suppose what I'm asking is, what is the ask in? So what's the specific ask? And because and to the CCG, is it money, or is it air cover to have a more lateral service around certain things?
I think it is.
Or is it a combination of both?
I think it is both. I think it is. You know, this is about equitable access to funding to prop up services in communities. So I'm speaking, you know, very much as a representative of my community. I want to ensure that my population doesn't have a lesser service in primary care because it's had to provide a flu service on top of everything else that it does, in a way that hasn't happened in the city. So it's not to take away anything from the city, but to ensure that there is investment in practices to support the additional work that's being done. It is important, I think, that we find a way to ensure equitable funding, even when you can't create a new service in a mass vaccination site. And I'm really mindful of this because of COVID vaccination coming as well. And certainly the population that I represent will not have ready access to mass vaccination sites in urban areas. So I am keen to ensure that vaccination doesn't strip away the other available appointments in primary care. We don't have the luxury of a workforce that can move into our areas to be able to prop up our vaccination attempts either. And you'll know that the rural areas are very good at delivering vaccines. So there's no concern about how many we're giving, but that does come at a cost. And I think we need to have sight of that practical cost on delivery of care in primary care in order to be able to achieve that.
Okay, thank you. Ruth, did you want to come in? And then we'll go back to see if Phil wants to come in.
Yeah, just two quick points, because I'm aware we've been on this for ages. Number one is, yeah, I agree with Helena in some ways. So we've done a very good campaign in my practice. It's been advertised, and hats off to my practice. But when I reflected on what Helena said, possibly that has come at the cost of our healthcare assistants maybe being able to deliver, for instance, learning disabilities checks, because they have been doing, you know, predominantly flu vaccinations for quite a long time. We are trying to do both, but one will affect the other. And then I just really also with the mass flu vaccination programme in York, which you know, sounds like a fabulous programme. It was just, have we got the data to show that it has been effective? Because I've seen a couple of things in the press, and I know from my parents who are registered in a practice in in York, that there have been problems in some practices with people being able to access and book the appointments online if they don't necessarily have the equipment to be able to do that. And have we disadvantaged people with digital access problems? So for instance, in my parents' practice, not them because they're very good on the internet, but I have heard that there have been a lot of elderly people who have struggled to be able to figure out how to book an appointment and go to the mass vaccination site. So although on paper it sounds very good, and there may be good data to show that it has been very effective, I just suppose we need to just make sure that actually that is the reality of it, and have we got the data to prove that? I don't expect you'll have the answers to that now, but there's just some concerns about those particular populations who might struggle with the mass vaccination site, and whether practices have done enough to cover them off and deliver them in-house. Yeah.
Okay, thank you. So
we'll look into that, Ruth. Yeah, we'll look. I don't have the data to hand, but I know that there was, obviously they wanted to set up and start really quickly, but it was reliant on other practices in the city giving them some vaccines in order for that to happen, and that was variable. So they could only do some patients and not all to start with, and then it's got going a bit more. But in terms of the data and that access to booking, we'll look into that.
Yeah, we could get this brought back to the governing body for feedback. Phil, did you want to come in, or Steph, did you want to come in?
Yeah, I will, if I may, Nigel. Thank you. So Helena's challenge was, as a governing body, are we assured about equity, and that we're not creating any health inequalities? I think it's a very reasonable issue to raise for us, and a very reasonable challenge. It's quite hard to respond to, because we should look at it all in the round. So when we were first, for example, so the mass flu vac development in the city, when in exec we were first hearing about that, exploring that, we were really aware of, well, what about the north? What about the south? We were really aware of that. So awareness is good. That's different to being able to do something about it. However, looking at it in the round, as Michelle indicated earlier, as a CCG on behalf of the governing body, we are providing more support into care homes across the Vale at the moment than perhaps we are in the city. So your question is a good one as well, Nigel. You know, what's this about? Is it about money? Is it about effort? It can be a whole range of things, really. So as we go into this next, I don't know, 6 months or so, I think it's a very reasonable challenge for us to keep coming back to, as we see pressures in different parts of the Vale, and as we respond to that in different ways. And if any of our practice reps, Ruth, Helena, or Chris, feel as though the actions we're taking through the exec, or the decisions that are being made through exec or finance committee, are not equitable, I think it's absolutely right to raise them in this way, and we should respond and have this debate. I'm not going to offer a solution, I'm afraid, but it is something we are very aware of, and we should continue to be aware of. And if we're not getting it right, or there are things that we should reconsider, then Nigel, I think it's absolutely right we do that, and we should minute this and probably consider it outside of the meeting, and at the next governing body report back on a sort of holistic assessment of where we think we are, and equally what we think the similar risks and issues could be that present over the next 6 months, so that we can be less on the back foot than we were in wave one.
Yeah. Okay. Thank you very much. Okay. Michelle, did you want to continue on with anything in your report? Or?
I'll just pick out one or two little bits, because I know time is pressing. There's some information in there about the CHC team and what they've been doing, and I think it's good to sort of highlight that to governing body. It's a bit of a hidden service for us, and they do a a really difficult job and difficult circumstances, and often in very emotive situations, which is why we get more complaints about CHC than anything else. But you can see there what they've been doing, and they've been working in the discharge hub to directly support people getting out quickly with the right support. They've done lots of welfare checks. They've done lots of reviews virtually, and now face-to-face reviews are to start again. And so they've been busy doing that, and we've increased the workforce in order to do that. So I think it's good that we can see that there. And then the only thing I was going to mention was the Healthy Child programme that we talked about last time in the private session, because the consultation documents weren't out, and the concerns that we had about cutting services within the Healthy Child programme in North Yorkshire County Council. I've picked up a conversation with Richard Webb and Louise Wallace to let them know that our governing body has a series of concerns about that. But the documentation and the consultation has only been launched last week. So we want to take some time to look at those in detail and then formulate a formal response. And there's a few of us getting together, I think it's 11th of November, in order to do that. It's quite an honest representation on the website about the reasons for that, in terms of the cuts to the money that they have available, and then they're having to fit the services into that financial envelope. So they've been pretty honest about that. And then the only other thing I wanted to mention, which is not in the report, but a commitment, I guess, to governing body, that there have been some queries over what services we might provide to support bereaved children in particular, but adults too affected by suicide. And although we've done a little bit of digging over a couple of days, it looks like it's national services that we might be able to tap into, but that we might not have a local offer. So we're going to have a look into that and see what we can unearth, and see what other people are doing, and see if there's an improvement we can make on what we do to support those individuals. I could do the risks if you want now, but they are part of Helena's report that she's doing on risk in the Bath, so we can do it there. But we did want an agreement that we add a risk to the risk register, which will be looked after by QPEC, which is the fact that we had a discussion about the serious quality and safety issues about one of our care homes, which is subsequently closed. And of course, we have a risk that because of COVID, we don't have the assurance and oversight mechanisms that we normally have. And so I think that is a risk for us. Could it happen again in another care home? Potentially, yes. So we wanted to add that and need governing body support to add a risk.
Great, thank you very much. Now it would be good if we could pick up the other risks in Helena's report, if that's okay. Ruth, did you want to come in?
Yeah, can you hear me? Okay. Just on the Healthy Child programme, and the fact that it's come out to consultation now, it was really a plea to see if the CCG can help with communicating that out across the sort of particularly primary care, but the key people, because sometimes these things just go out to consultation, get quite hidden, and the true reality of those cuts aren't properly acknowledged. Because I read the way they'd put it in the paper, and they've put a very positive spin on it, and actually the reality is completely different, really. So an honest consultation about what's going on, but just whether the comms team can do something to make sure that it's getting out as widely as possible for people's comments.
Happy to do that.
Yeah,
and then we ought to do. Sorry, go ahead, Ruth.
Yeah, no, and it was just a thank you about the bereavement by suicide piece.
Okay.
Yeah, thank you.
I think certainly if we were to change a service as is potentially intended for North Yorkshire, we would do a quality impact assessment, and you can see on their documentation that they have done that. And yes, it was a moment in time in February when they were going to launch the consultation, but it did suggest there'd be no impact, and that would not be our view at all. So yeah, we will make sure that we formally respond and then give the opportunity to practices to do the same. We'll share that consultation.
Great, thank you very much, and thank you, Michelle. So if that's okay, we'll move straight on and pick up the risks that you've outlined in the next report as well. Is that okay? Yeah. So that means straight on to Helena, if that's okay, for the risk report and board assurance framework.
Okay, thanks. There are 4 risks, all from QPEC, that have reached the criteria for escalation up to governing body. And those relate to 12-hour trolley waits, hepatitis B vaccinations for renal patients, CQC involvement at York Hospital, and the Healthy Child programme at North Yorkshire that we've just discussed, the consultation. In the report, you'll see that we've set out the mitigating actions. So the question for governing body was, is governing body satisfied with the mitigating actions? And also, is governing body happy for these risks to go back to QPEC in effect to be dealt with by QPEC, or do they need to remain at governing body level for oversight? And I don't know if governing body have views on that.
Great, thank you. I don't know whether Julie, whether you wanted to come in as chair of QPEC around that and the assurance that for governing body.
Sorry, it's a bit slow technology, isn't it? I think it'd be really helpful. From my point of view, I'd like us to have a bit of a discussion, see what other people feel. I know what my views are, but that's just me. So if we could have a little bit of a discussion, but
yeah.
I'm happy to take them back, but when we've discussed it fully.
Would it be helpful if I just gave a quick overview of where those risks are? Because I think they have changed, certainly in the
yes,
couple of months. So the 12-hour trolley waits were a significant concern to us at governing body, not just because of the way that they're measured, because we'd also have concerns about people waiting, 8 hours on a trolley and the way that the clock starts ticking. So it was the quality of services that we were concerned about if somebody had to remain on the trolley. What, of course, we've seen during COVID is no 12-hour trolley waits. So you could say at the moment, that isn't a risk that's materialised, but it will do, I'm sure, during winter. And certainly Scarborough, day before yesterday, was so busy that they just got away with that by the skin of their teeth. So, is it significant enough risk to be escalated to governing body at this time? Probably not. It probably needs to sit with QPEC to have an eye on it, is my view. And then if things start hotting up and we haven't got the assurance, then it should come back to governing body. Healthy Child programme we've talked about, and we would want to keep that here in my view. Hepatitis B. So let me just tell you where we are with that. So a very clear indication from NHS England that it should be delivered by the acute hospital. A view from our governing body GPs that we shouldn't mess with something that wasn't broken and it should stay in practices. That wasn't the view of the LMC. It's taken quite a long time, over a year probably now, to get to a point where there is an increased cost being agreed to fund additionally for practices to continue to do it until April next year. And then with the same service that you get from the hospital about when somebody's due their vaccine and when it should be given. And then move it to the hospital after that. So we will need to work with the hospital about being ready. And again, there is an increased cost to the CCG, not insignificant, in order for them to take that on, because no funding came from NHS with the decision that they made. So, there are risks that people will slip through the net currently with this two-pronged approach, and we haven't yet got all practices signed up to continuing to agree to do that until next April. And I think there's communication about to go out to practices to get them to sign up to that. Steph will know better. But what I think is really clear from exec is that if practices are going to sign up to continue to do it till April, it's all in or not. So if we have a patchy service, that increases the risk. And then we could possibly, if that happens, we could possibly consider asking that to be done on a PCN basis. So I think that risk needs to sit with governing body at the moment, is my view.
Great, thank you very much. Anybody got David, did you want to come in? If you still can't hear you, David, unfortunately. Okay. Chris, did you want to come in? Can't hear you. We'll go to Simon.
You are on mute, Chris.
How's that?
Oh, that's better. Go on then.
Yeah, I've got several different mutes. Yeah, so it was the 12-hour trolley wait risk. In the mitigating or comments, there was just comments, no kind of mitigating things for that. And I agree, Michelle, that it's not yet something that maybe needs to sit with governing body. The numbers don't look bad at the moment, but they inevitably will. So it would be good to have some mitigating risks. I think the urgent care managed change should sit in there as one of the mitigating risks. I don't know if other people agree with that, but it would be good, yeah, to have something in there to say this is what we're planning because we know it's coming.
Okay, fair comment. Fair comment.
Okay, Simon, did you want to come in?
Yeah, probably just a presentational issue. I mean, it wasn't immediately obvious, and it should be, why some of those risks were escalated, because some of them look like they're declining, some of them look like their scores aren't sufficient to warrant governing body interest or oversight, and as Chris has pointed out, some of them lack mitigations. So I think there's just something for us to continue to do, which we have been doing for the last couple of years, in developing our risk reporting, our business assurance framework, linked back through to strategic objectives. We'll come on to this in a bit more detail. These things are always difficult to achieve, but more work still needed, I think, in some of this presentation.
Okay, thank you. So, Michelle, does that help about where things should sit, do you think, for us? And Helena?
Yeah, and just the one about York Hospital and the CQC risk. It's just stayed there because the CQC has seen significant improvement and have asked the trust to apply for removal of the conditions that they put on their practice, their regulations. So they're ready to do that. They just wanted to make sure that they've dotted all the I's and crossed all the T's, particularly around children in A&E. And then the CQC will remove those regulations. So the way that risk is described should then allow us to take that off.
Yeah, okay. Julie, is that helpful?
Yes, thank you. It's very helpful. I think Michelle and I can catch up anyway outside of the meeting and discuss it a little bit further if that's okay with everybody. But I think it's helpful to have that discussion. In our meetings, we've often got our own tunnel vision, and your thoughts are very helpful to help us to sort of measure how we're approaching things. So thank you all.
Great. Okay, so we'll go back to Helena, if that's okay, around.
Yes. The next thing was the board assurance framework, and you should have had this as a late, apologies for that, additional paper which sets out the current state of play for the board assurance framework. I don't know if Michelle is able to share her, Michelle Seidman is able to share her screen to show that for anyone who hasn't seen it. If you haven't already seen the paper, it sets out the 6 objectives of the CCG, and then for each objective, it sets out a number of actions proposed to achieve that objective, together with any risks against achieving those actions and objectives. And then on the final page, there's an overall summary of all the risks and the state of play of those risks, whether they're static, improving or deteriorating, together with the RAG rating. So the theory is that the final page of the board assurance framework is a summary of everything, of all the risks, all on one handy page. But the purpose behind this is to provide the clear linkage between the strategic objectives and the risks.
Yeah, thank you. Yeah, and I think it's hard to share on this platform.
Okay.
Simon, did you want to come in?
Yeah, I guess again, I mean, being a bit pedantic, but as is my want, it was shared late. Appreciate people are working flat out. Some of the strategic objectives we ought to spend a bit of time on and agreeing. The risks should emanate from our assessment of how able we are to deliver our strategic objectives as has been agreed. Again, late updates that have been provided over the last 24 hours aren't included in these papers. So difficult for this governing body to respond to live documents that aren't complete as we speak, but important for everybody to acknowledge that it's not quite there yet. So yeah, not great, but you know, we're making progress.
Yeah, Michelle, do you want to come in?
Just to say, in terms of the process to get the BAF in this draft version, as Simon said, it's not a finished article at all, was that we wanted deputies to start to work on it. And they've done that through their group and individually. And then they were to share that and explore that further with the exec that was linked to that strategic objective. And yes, the timeliness of that could have been better, but we did also make a decision that the BAF would come late, not with the normal papers on a regular basis, because we wanted it to be as live as possible. Now, if we're saying we do want it to come with the papers, then we just need to make that agreement and then set up the processes before that to make sure it's had the right scrutiny and oversight and work on it before it comes here. But as Simon quite rightly says, it is draft. They've had a go, and then execs have also expanded it a little bit on what the strategic objectives should be. So I think that is a question for governing body, is do they seem about right, given that we've got to do a bit more work on the wording and then the priorities that come out of that. And then just to say the things that we've picked related to those strategic objectives, the question we were asked were to concentrate on the next 6 months. So although there might be other things related to it, the priorities for the next 6 months has driven the words that are attached to that, if that makes sense.
Yeah, so Michelle, you said that the strategic objectives are the imminent strategic objectives of this next 6 months? Or?
They're a suggestion to governing body, as was the ask last time, to have a go at rewriting our strategic objectives. So I think we need to have a view on whether they're right ones to have at this moment in time.
Yeah.
Everything else should then fall out of that, you know, how we address the risks, how we have appraisals with staff, etc. So they are significantly important.
I think the format's absolutely right, and to me it works well with that point of view, and that you can see where things are, especially that last page. It's good. I suppose it is about whether those strategic objectives right at the front are wide enough in a way that they don't need changing every month.
Yeah.
A bit back to that sort of like thing we were talking about right at the beginning of your report around principles. It's sort of like wide enough that things can fit in it, but narrow enough to show a direction of travel. I don't know whether anybody else has got any thoughts or comments on that.
I mean, for me, those are the things we're concentrating on. So it's useful to come here and think whether or not we should be concentrating on other things. But those are the things that are present in our daily lives. I guess, I mean, we've established the fact that this is a draft document and that's how it's being presented to governing body for comment. I think we probably need to be a little bit more disciplined in making sure that we're clear on what papers are coming for what purpose. This is a commentary piece, if you like, but absolutely, those are the things that we are spending our time doing. So absolutely right for governing body to comment if those aren't seen to be the right things, or if we've missed something.
Ruth, do you want to come in? You're on mute.
Sorry, can you hear me now? Yeah, just really quickly, given our conversations today and in the last few governing bodies, I wonder if we need to include something about health inequalities in there. I don't know where it might sit. It might sit with the safeguarding the vulnerable. I'm not sure. It's just coming up quite a lot, and whether we need to just put it in there to make sure that we're assuring ourselves regularly about health inequalities across the patch. That's my only comment.
That makes sense.
Yeah, I think I'd support that. I think I'd want us to focus on the reality of the situation, which is in the last 10 years, health inequalities have significantly worsened and widened, and that's been driven by national policy. So whilst it is our stated aim to bring down health inequalities and to have an equitable approach to funding to improve health outcomes, we're doing that in a context which we aren't necessarily in control of.
Yeah. Phil, did you want to come in?
Yeah, thanks. Just to say, yeah, a good point, Ruth, and I agree with that. Support that, and not only should we have an eye to that, but there's something about the context of thinking about where the NHS is going and this governing body helping to steer the future structure of our local NHS in a way that this governing body can also be reassured that not only are we making sure that we're working towards narrowing those inequalities, but the structural changes that may come in the NHS are aligned with a continued focus on that as well. So not only operationally should we have an eye to that, but strategically we should steer that, and governing body be assured about that as well. So I fully support Ruth's point.
Thank you very much. Okay. So, Helena, is there anything else that we should note, or is that enough feedback? Do we think at this point in time to take things back, and then we can keep close to this? Would that be okay?
That's fine. Basically asking if you're okay with the direction of travel, and obviously taking into account the points that have just been made. Can I assume that the direction of travel is broadly accepted?
Yes.
Yep. Okay. Yeah. Thank you.
Yeah. Great. And thanks for your work and coming to present today. Thank you. Appreciate it. Okay. So I think what we'll do is we'll do the next item and then have a break, if that's okay.
Sorry, I think Michelle was. I think Michelle was waving rather than agreeing.
Okay.
Just wanted to nail the question about when you receive the bath, because obviously a lot of work goes on through deputies and then to execs before it gets to you. So I think we need a steer in terms of whether you are happy with it coming late to keep it as live as it can, or whether you want it with the papers.
I wonder on today's discussion whether it needs to come with the papers so people can have a good look at it.
Yeah. Okay.
I think that probably would be sensible, and we'll see how it goes.
Yeah. Thank you.
Okay. So thanks very much. We will move on into the next bit of the agenda, if that's all right, and then have a break after this. So hopefully we'll be able to spend about 10 or 15 minutes on this next bit. And I think, Simon, were you going to introduce this? Were you going to introduce Steve and this?
Yeah, so this is the counter fraud response to a request from primary care to support their general awareness of fraud risk and counter fraud opportunities and support available. It is specifically an NHS England responsibility to support practices with fraud, but that's been a little bit patchy, I think it's fair to say, since 2012. And we've had a number of instances locally where risks have become realised and the request came from this governing body to support practices in a wider sense, which is what our counter fraud colleagues have done, and the document that Steve will talk us through is the product of that work. So that's probably all I need to say by way of introduction, Nigel.
Great, thanks. So can we hand it over to you, Steve? Is that all right? And maybe if it's all right, just to pick out the points that you think we need to discuss or to emphasise at this governing body, to put weight on it, because I would hope that colleagues have read through, and I thought it was a very good paper and very good document actually. So thank you very much for bringing it. So I'll hand it over to you, Steve.
Nigel, Steve just asked me about unmuting, so I don't know whether there's an issue. Is comms able to help?
Maybe it's the same issue that David had. I'm not sure.
Can you see me now?
Yeah, perfect, Steve.
Good morning, Chair, and thank you, Simon, for the introduction. Yes, we were asked to put this guidance together, and it was born out of the fact that there were a number of high-profile GP fraud investigations across the country, and it almost felt like the GP population had been neglected in terms of any fraud guidance. After speaking to Simon, I contacted the National Body for Counter Fraud for the NHS and asked if they had anything in the pipeline that we're proposing to do, and it wasn't really on their agenda. And similarly as well, I contacted NHS England, who have their own fraud team, and again, it wasn't something they were looking to produce. So with Simon's blessing, we put this together. And basically, I appreciate it might be quite lengthy, but it maps out really what fraud is in the first instance, just to make people aware. It makes people aware of what the types of fraud you're likely to encounter in a GP setting as well. So, obviously prescription fraud is something that happens a lot, but also you are subject to all sorts of frauds that we see elsewhere in the NHS. So we're talking things about mandate frauds, pre-employment checks, phishing scams, unsolicited goods and services. So we've tried to map those out in there, but probably more importantly than anything, we've tried to outline maybe things that you might want to consider within a GP practice. And it could be that practice managers are all over this and partners are all over this, but we thought it might just be handy to have a checklist in there in terms of determining whether you have controls and checks and balances in terms of changes to payroll, the bank mandates are up to date, that you have necessary processes for pre-employment checks as well. So we've tried to map those out in as much detail as we can. I think the complicated thing about GP practice fraud is the fact that it potentially might fall into a number of different organisations who end up picking it up. So it could be something that we pick up on behalf of the CCG. It could be something that NHS England end up investigating, or it might be something that the police are looking to investigate. So what we were hoping to be is almost like a conduit for the members' practices in terms of if you have any suspicions of fraud, if you want to make them known to us, we're more than happy to determine where the best place is to take them. And also, if you have any concerns that you think you might have weak processes or something that needs a more robust check, we're more than happy to provide some support there in terms of adding our advice, some guidance. So it was basically that's what we're proposing to do. I appreciate that the GPs and members haven't seen this with the exception of Simon. So if anybody has anything they'd like to add or like to see in there that's not in there already, I'm more than happy to tweak it before it gets circulated.
Brilliant, Steve. I thought it was an excellent document actually, and it's amazing that nobody had really thought had concentrated on this. The issue is, isn't it, that we're all different small businesses and we run our small businesses slightly differently. And we've seen over the number of years that unfortunately colleagues and employees have been able to use the sort of the different ways that different small businesses work to be able to defraud. So I thought it was excellent. So thank you very much. Just wanted to say that. Ruth, did you want to come in?
Yeah, no, only to say thank you, because I know I was one of the people that was pushing for this, and I think it is extremely helpful. I'm just really keen that we share it widely and in a way that people really actually read it and you know and are aware of it. So I'm wondering if we look at several ways of doing that. So I know we've got, I wondered if we thought about a PLT session on fraud, or a breakout group on fraud at some point. I don't think it necessarily needs to be in the next couple of sessions, but it's a really important thing for primary care. And I think if you just send it out as an email, my worry is that people don't really pick it up and really process it and read it. So it's about making sure that it's as impactful as we can make it. Really.
Thank you, Ruth. Regarding the point you made about the PLTs, I think we were due to go to one in March, and I think obviously it was rescheduled. And I think we attended one recently in October. And I think if the opportunity presents itself again to be invited, we're more than happy to do that. And similarly as well, you know, any thoughts anybody has in terms of the best ways of promulgating and promoting this, more than happy to take those on board.
Great, thank you. Simon, did you want to come in? And then I wondered about Andrew from a LMC point of view, whether you wanted to comment on how we could support practices with this. So Simon first.
Just to say, really, to offer this out to practices, we have done. This guidance comes on the back of a PLT, but there's absolutely no reason why we can't do more in terms of webinars and online guidance. It supports the work on conflicts of interest training that counter fraud and internal audit colleagues are helping us with. So, you know, I think we recognise there's opportunity for us to support practices in the good operation of their business and keeping the public pound and their reputation safe. So yeah, really positive progress, but something for us to keep an eye on and support.
Great, thank you. Andrew, from an LMC point of view, is there anything that you think that we could do to highlight this good work as well? He's there, maybe he's having IT issues. I think definitely it's something that we can highlight, Steve, across a wider patch as well, because from the sound of it, this isn't being done anywhere else. Is that right? No.
It doesn't seem to be, Chair. Certainly from doing a lot of online research, there wasn't anything I could see that was happening in any other areas. And so,
okay.
Just for context, we cover a number of CCGs. So I think if our CCG is happy with that, I think we'll look at implementing it across the ones in North and West Yorkshire as well.
Yeah, and I think from a sort of like a Humber Coast and Vale ICS level, I'm thinking with my other role that if you're happy and people are happy here, I'll be wanting to share this good work because I think it's great, really is.
Oh, thank you.
So that's good. Okay.
Thank you very much, Chair.
So Phil's put his thumb up, so lots of thumbs up. So that's great. So Steve, thank you very much for that important piece of work, and thanks for coming to talk it through with us. What we'll do now, everybody, if that's okay, is we'll have a bit of a break, and then I'm going to give you 10 minutes. So if you just come back just before 15:15, and then we'll get on with the rest of the agenda. I would say just put your cameras off and then go and have a quick break, and then we'll come back at just before 15:15. Thanks again, Steve.
Thanks, Chair.
Right. Hope everybody was able to have a quick break. I got sent in a bacon sandwich. What a great thing that was. That was a surprise. Anyway, maybe I shouldn't share that with everybody, but I'm going to. There you go. So that was good. Right. So thanks very much, everybody, for coming back. Now, in the next bit, just get the agenda back up. I've had an apology from Caroline Alexander because she's been asked to go into an urgent meeting around surge escalation. So we're going to have to note items 11 and 12, if that's okay with people. I've just given you that warning. So if you did want to comment on anything, then please put it in the chat box, and then I can take that back, and we can deal with those. Okay. So going to move then straight on, and this is back to you, Michelle, around COVID-19 and staff risk assessment.
Thanks, Nigel. So Helen is going to come and present the report because she wrote it. And you might remember it should have come to governing body last time we met, but there wasn't room on the agenda. So this is why it's here now. So just to give governing body assurance, really, that we have undertaken the risk assessments on all our staff and how we went about it. So over to Helena, if she's back from her.
Yes, I'm back.
Thank you.
Yes, there was a national ask that we risk assess all our staff. There was a similar national ask for GP practices, and we've attached the letter with that national ask as Appendix A to this report. This all happened in June. There was also a national or nationally approved set of guidelines issued by NHS employers that shared some of the questions around medical conditions that employers might like to ask. So we carried that exercise for all our staff, led by assistant directors, and have been able to risk assess all our staff. We now have that information should risks levels change. We were beginning to have to look at this at the point when it looked in early September as though staff might be requested to start going back towards office working. Obviously, we're now back into a national lockdown situation, so we're back where we were. But the information from these risk assessments will inform any potential return to office or to other work, including face-to-face work with patients as we go on. I think GP practices will have had similar information, and they were all asked to confirm that they had carried out risk assessments for their vulnerable staff. I don't know if there's any questions on that.
Well, we will ask. And anybody got anything that they want to pick up on this at all? Helena?
I wanted to ask some advice here, because I think it's quite straightforward when you're an employer. Can you hear me all right, everyone?
Yeah, that's better. Thank you.
So I think it's reasonably straightforward as an employer. Yeah.
Slightly different in the GP partnership model because you're not the employer. So I want to just ask and perhaps raise a risk here that there are GP partners from BAME backgrounds who have got quite competing pressures, A, to follow a risk assessment, B, to run their practices, who might not have the ability to step away from frontline services. So has the CCG kind of looked at that at all? Is there, are you aware in practices where it's particularly partners that might be affected, and had a discussion with that? Because I think that's a particular vulnerability in primary care that is different to other settings. It's very different when you're self-employed and you're running an organisation and there isn't somebody else to come and do your on-call for you.
Yeah, we haven't specifically asked for that information to come back to us. We were simply asked to reassure NHS EI that risk assessments had been carried out. What happens with that information is perhaps a separate matter, and at the moment it has been left at practice level for practices to agree at that practice level what happens with that information.
So there is a real conflict of interest for GP partners who are from BAME backgrounds or who carry moderate or high risks to be able to address this. And I think we need to acknowledge that and actually make this meaningful by ensuring that there is support for those practices that are affected. There are some practices, for example, who have significantly older GPs as their workforce, small practices with very little flexibility. The options for hot site, cold site working are very limited. So their practices will fall over if they work to the risk assessment. So I understand we're kind of leaving that as a practice level decision, but have those practices actually got a choice? I think that's something we really need to be aware of, because there is an immense pressure to continue working despite risks as GP partners.
In your view, would practices be prepared to share risks to their practice with the CCG if we put a call out for people to share their risks? Is that something practices would be comfortable sharing?
Nigel, you might answer better than I. I don't know. Individual. It's
I
very
think
sensitive.
I think that's a really good question, and it might be something that Andrew might want to come on from an LMC point of view. But I think it's a really good question, actually. But Helena picks up a really good point, which is about service continuity when you're a partner and you're you're the cohort that have to pick up the work. And actually people possibly are nationally putting themselves at risk by picking up work that they shouldn't do because they feel they have to.
I am aware of people who are saying, no, it's fine, I'll carry on. But that's not what you would do if they were an employee. They're only doing that because they're a self-employed partner and they don't feel able to say, I will step away from the frontline higher risk activity.
Yeah. Should we bring Andrew in and then Ruth? Is that okay? So Andrew?
Yeah, I agree. I mean, it's a hugely important point, and I think it applies to all partners who are clinically vulnerable. I guess I don't see an issue with the sharing of data. I'm sure practices would be happy to do it. I'd question sort of why that step would be necessary, I suppose. And actually, is it just a case of communicating to practices that there is support for those who need it, rather than requiring that data gathering process? And I just saw Steph Porter's comments in the chat, and I suppose it does tie nicely with the Opal stuff potentially, and knowing that there is that backup and options, because as people have pointed out, if there's no option, the practice needs to operate, and it's going to be it's the partners who have to do that. So
yeah, thank you. Ruth, did you want to come in, and then Julie?
Yeah, no, I think Andrew's right, though. I don't think we can make practices share that data, but I think we can say that we have discussed and identified it as a real risk here, and as a CCG we can kind of take the lead to say that we are aware that practices may feel under, and individuals, particularly GP partners, may feel under a huge amount of pressure to maintain their working when they are high risk, and actually it may be up to us as a primary care community to come together and support each other and offer some solutions to those practices, because there should be solutions that we should come together as a community to support those individuals, and they shouldn't be putting themselves at undue risk. So, you know, I've got a big enough partnership, I think. So we have one partner who is higher risk, and, you know, we have risk assessed that and taken them away from any hot type working and trying to reduce the clinical contact. But I'm aware that other practices won't be able to do that, and we should take a lead on this, really, as identifying it as a problem and trying to push the primary care community to come up with a solution.
I think there's two bits to it, isn't there? As a CCG, we need assurance that they've undertaken risk assessments to start with, and getting assurance on that. And then the second bit, as you both raised, which is a really important issue about the effect of those risk assessments and what actions they feel they need to take or want to take, and then how we wrap ourselves around them to reduce the risk to them as individuals.
I think Steph's comment in the comment box about how this links to opal pressure, it might be an effective way forward. How many doctors have you got working at moderate high risk in doing potentially hot site work? Because if all of your doctors are moderate or high risk and they're all doing hot site work, then your practice might be reporting opal 2 pressure, but actually that's a practice that's putting medical staff at risk. So their solution to managing that pressure is not a safe one. You know, in my area, that's a particular problem.
Julie, did you want to come in?
Yeah, I absolutely agree with what everyone's saying. We took, you know, we took a huge amount of time pulling this information together with the help of our other colleagues and David Booker's help here. And we're sending 2 different messages out. And we need to let GPs know that we're on their side, that we're giving them permissions that they feel that they might not have, but we need to resolve how we're going to do that, and especially thinking about the tiny practices and how that's going to be tenable for them.
Yeah, absolutely. So I'm wondering whether Andrew and Steph, whether that gets sent back through the sort of the opal stuff that Gary Young and the LMC have been working on, and just to sort of just add in that extra richness and see where we can get to. What do you think?
Yeah,
I can certainly feed that back on my side.
Yeah, and we will certainly do that. There's an immediacy, isn't there, to just try and identify where the pressure point might be, where we might need to be really explicit about the help we can offer, both in practical terms, just to help share the burden of the pressure that the individuals feel to be doing this work for their patients when they're putting themselves at risk. So we'll do those 2 things.
Yeah, Andrew.
Yeah, and it is just you know, it's specifically the partner issue, isn't it? Because as you say, for employees, it is a little bit more clear cut. And I, you know, as a partner, I'm not sort of biasing this in any way, but I think there is something very specific about that situation of being the contract holder and feeling personally responsible. And the other thing I would just say is, you know, it comes back to the purpose of the opal in the first place, is that if we don't feel confident that there's a solution in return for you raising a concern through the opal process, then it's kind of a useless process, really.
Ruth, did you want to come back in? No. Okay, that's fine. Great. Okay. Elena, Michelle, anything else to pick up on this report?
No, it's been
not for me.
No, great. Very helpful discussion. Thank you very much for bringing it. Okay, so we will therefore move on in the agenda, if that's all right. And then this is over to Denise, if that's okay. And I think we have sort of touched on this a bit, Denise, haven't we, around SMI and LD a bit earlier on in Michelle's report. So maybe we need to just pull out some bits here and then sort of maybe get some further actions around it, I think.
Yeah, thank you, Nigel. As you know, we touched on it today, and this is probably the third report that governing body has received around, and particularly severe mental illness health checks. Just a bit of an update since that report was written. We now have the practice that was undecided signed up. So all practices for the Vale of York, with the exception of 2, have taken up the LES, which is great news. And thank you to Andrew and the LMC for supporting that, because I think that's been really helpful and made a difference. I guess the question for governing body is, given that there are 2 practices who haven't signed up for the LES and who are then not providing data for us to be able to monitor it, how do we want to take forward those issues, which clearly could end up in some inequalities for those practice patients. I'm relatively pleased that we've got Q1 data at 24.7 and Q2 at 22.6. And it's not anywhere near where we would like it to be, and it's a drop from the end of the year. But given COVID, I think what it does demonstrate is that there is an increasing awareness amongst practices, and it's increasingly important, being seen as an important thing to do. So I think the messaging is getting out there, and the dedication of the practice teams is also there. Looking at the data, I guess what I see in it is things that Ruth has highlighted to me before when we were initially developing the LES. There are an awful lot of contacts for this cohort of patients, and a lot of them are having some of the intervention, and yet not all of the intervention. So there is really a real opportunity to do more at the same time. If we are seeing people in practice to say, for example, have their BMI and their weight checked, then that's what the data is showing us, but we're not seeing anybody really, or very few people, to have advice and guidance about diet. And those 2 things are linked in very many instances. So I think there's a great opportunity to do more. I'll leave it at that, but I would like us to discuss what about the 2 practices that are not signed up to the LES and the equality issue there.
Okay, thank you. I suppose that a couple of things would be around, I think earlier in the year, Ardens was made available to all practices. However, and so I think the Q1 and Q2 probably isn't reflective, going back onto Helena's point of actually where we're at in time. And I don't know whether we could get any sort of updated real data. That might be quite interesting. And because I think, Ruth, you picked up that the Ardens template, I think, drove quite a lot of improvement in the numbers, and I see you've put your camera on. So do you want to come in on a few bits?
Yeah, it definitely does prompt you to answer all the appropriate questions, really. I wanted to come back to Denise's point about the 2 practices, and I just wanted to know what their reason for not signing up was. Did they give a reason, or are they just disengaged?
No, we've asked Ruth. The first one refused pretty much immediately, but at that time there were discussions that the LMC might not support it, so it might have been linked to that. We've gone back and said the LMC have said this revised LES is okay. But it is still refused. And the second one has simply said it was a practice decision.
And without naming the practices, because I don't think that's fair, are they in the same PCN? Are they in? Is there an opportunity to use the PCN clinical leaders to apply pressure? Or even me. I mean, I could try. I don't want to get into arguments with people, but I would be prepared to just sort of try and open up a conversation as to.
Well, I think all help gratefully received, actually. There is a conversation this week with Sarah Ferguson to see whether there's an opportunity to pursue other practices doing this under open access on behalf of. And if that was the result and that was acceptable, I don't think anybody would mind with that. It's just I feel really uncomfortable leaving the inequity bit. How it's provided doesn't really matter, I guess, so long as the data's back in the originating practice. So we're starting to explore all of those, Ruth, but perhaps we could take a conversation offline, and if that offer of help, we'd be grateful for. Yes.
Yeah.
Helena, did you want to come in?
Sorry, now I'm going to get quite granular, but I promise I'll be quick. So if you get Next to create a series of searches that practices can own on their systems, and you pay practices a nominal fee, a tiny amount of money to produce evidence for that search and provide it on a monthly basis, you'll probably get the result that you actually want, rather than what's currently happening when you don't have any data and practices don't have their own data. So there are people who can create the searches, there are people who can embed it and help practices with it. All of those services are provided and those people exist within the system, and we're not using them, we're not doing it. And I think the other thing is, Denise, going back to those two practices, is it not their responsibility to identify who will be providing? You know, these are your patients, they are eligible for this. It's a concern that you're refusing to provide this. Who can they identify that will provide it if they, as the main primary care provider, won't do it? Again, use us to speak to those people, because I think that does need some direct challenge from clinicians to say, this is really achievable, really doable and well evidenced, and it's strange that somebody wouldn't do it. It's normally blindness rather than actually willful neglect, and I think it is very likely to be the former than an actual deliberate attempt to sabotage or worsen care.
Yeah, okay, that's helpful. Helen, has George or the BI people spoken to you about your idea, the Next, because they've been trying to work with Next to move on this? Have they got your, I suppose, nuanced information about it?
No, but they do know about the people in Next, Denise. So I think we, as a CCG, we have to take a little bit of responsibility for the fact that these people exist, and George is well aware of them, and people in your team are well aware of them. And I think this is, I think it's a fundamental of wanting to change for the better, that we have to have really good measurement being provided that's current and responsive. You know, a couple of clinical directors have said to me, I don't understand, if this data is available at the CCG, why have I not got access to it?
Yeah.
So the data that exists already without any additional searches is not being shared widely enough with the people who Ruth's highlighted could actually make a difference. But beyond that, actually, if you want to flip it into practices' responsibilities, you know, Steph is well used to organising searches for various different claims and leses and deses and practices. I appreciate Andrew will probably be head in hands when he's hearing me talking about providing reports and more administrative burdens for practices. And I don't want to go crazy on that. But clearly, if practices don't know how they're doing, it's very difficult for them to have a sense of improvement. Particularly I'm not in a particularly large practice, but in a practice of my size, I cannot keep a handle on every SMI check. So God knows how the bigger practices can really keep a handle on it without that data available and somebody actually helping facilitate that focus on change.
Okay, that's really helpful. And Simon and I will have a conversation about what the BI team can do to help this more, because you know, I think we're on the cusp of moving this on, aren't we, with so many people signed up to the new layers and so many practices. It would be a shame not to maximise it now.
Yeah, great, thank you very much. Ruth, did you want to come back in on anything? Julie, did you want to come in?
Yeah, so sometimes I think we're just that little bit too polite when people knock us back, and it's about pushing back and saying, okay, then, you know, at the end of the day, if you're not prepared to do it, then we will find a way to do it, because we do need equity across the patch. If we're getting information that's going to be useful, that's going to inform the future, then we need everybody signed up to do it. And if not, we need to find a way of getting that information.
Yeah, thank you. Andrew.
Yes, sorry to chip in. It's just, you know, I wouldn't be representing the LMC properly if I didn't say something about it. I think it's just the only thing I would say about this, Les, particularly for the SMI and not for the learning disability, is it's just that the funding, you know, wasn't felt to be great for it, and the LMC endorsed it as a pragmatic decision because it was an important thing to be doing. But in, you know, so that's fine. But in the case of those individual practices, in their defence, what it sounds like is that they've probably made a business decision as a practice that it isn't well remunerated enough to be a priority, which is a shame. But it is just something else to think about, I think, while you're having this discussion.
Steph?
Okay. Whilst we're talking about finances, sometimes we feel a bit uncomfortable about it, but if we relate it to the LD checks, where there is a significant financial incentivization for the work, we're not hitting those targets either. Although I take on board Helena's point that maybe our data isn't as fresh as it could be. But the point I want to make is sometimes money isn't enough, and we just have to acknowledge that our practices are getting a lot of requests at the same time. So just in the conversation about how we find a way to support practices to do both pieces of work that are hugely important and particularly relate to the inequalities agenda that we've already spoken about, that, you know, if money isn't incentivizing our practices, you have to ask why. And that's just in the context of everything that everybody is doing at this point in time.
Yeah, good point. Andrew, and then Ruth.
Yeah, I think the LD thing probably comes down more to the lack of awareness, to be honest. And I feel pretty hopeful that by doing the kind of engagement activities that are planned for the LD checks, you know, I agree with you, Steph. If that doesn't increase the numbers, I would be interested to know why that is, really.
Yeah, Ruth.
Yeah, I agree with what Steph says. I think at the moment it has been really challenging for primary care. We put things on hold with COVID. We've had a lot of different asks. It's been really destabilizing. And I think, you know, people were just about getting back to trying to get all their kind of long-term management things back in place. Then COVID increased in this area, and we had lots of, you know, staff shortages or staff pressures due to people being off and self-isolating. But also I think practices for a long time have been focused on demand and not need, and they haven't, they're just firefighting all the time, and they haven't, all practices haven't got enough space or the right people or people in a position to step outside of looking at demand and looking at need, and the fact that we do need to step into prioritizing need. And it is a challenge. I know, you know, I'll be honest, in my practice, I'm, you know, a massive advocate of SMI checks and LD checks, and we're not doing them as well as we could do because we just haven't got the capacity and the space at the moment to do them like we would want to do them. So there are plans in place to try and address it, but I'll put my hand up and be the first to say we're not hitting those targets, and we haven't for the last 6 months because there's just been too many other pressures. So yeah, we just have to keep figuring out how to support practices to get their head above the demand and focus on the need.
Yeah, thank you, Ruth. Denise, has that been a helpful discussion? Is there anything else that you think
it has? If I
do?
can just have a couple of minutes, Nigel, and move us on to the LD checks, because I've got the latest position of that. We've now got the Q2 data, only just last week, and it's shown that in Q2 we've managed to do another 162 health checks in that quarter. So that's very good. That's against our target of 181. That, just to put that in context, that's delivered an income of around £22,500 to practices for those health checks. There's still a lot more available and a lot further to go. Similarly, we have 2 practices that have not signed up to the national DES for this. Both Fiona and Gary are working to discuss with those practices what they're missing out on. We've obviously around that. But also in Q2, there were 5 other practices who had signed up to the national DES but hadn't submitted their register size, which is the first part. Before you submit how many health checks you've done, you've got to submit your register size. And since they hadn't done that, we haven't been able to count any of those health checks either, if they've done any. So actually, the 162 health checks, there may be more. Obviously, those practices will be able to go back and address that, and we're trying to work with them to understand why they haven't been able to. May well come down to Ruth's point that people have just not been able to get their head above the here and now and submitting some of that data. But it obviously, it's really beneficial for the clients and obviously financially beneficial to practices. The York situation, Carl is working at the moment with Priory and Dalton Terrace in terms of an improvement plan. So we're starting to get much more engagement across the city around this agenda as well. And tomorrow there's more training, which Dr. Blades and Ruth and Tuve are doing, so that practice GPs, practice nurses, and anybody involved in the pathway actually can do as part of that online training. We'll make sure it's videoed, so it'll be available to people who can't make it, and we'll do as many as we need to do if it evaluates well.
Great, thank you. And I think I did highlight to regional colleagues also about tomorrow's lunchtime activity. So, because I think that sometimes we don't get the exposure of what actually you're doing and how much we are promoting this. So hopefully they can come and help and also understand what we're doing.
Yeah, great. Thank you.
Anybody want to come in back on anything that Denise has said about those bits? No. Okay. Denise, anything else you would want from the governing body at this point, or happy to keep it live and bring it back?
No, I think just let's keep it live. There's lots of we've trying to, for all of these inequality areas, we're trying to put bids in for winter funding for care coordinators and so on. So whatever opportunity we can get to help practices, we will do so. And just thanks for your support and offering to help with other practices. That would be great. Thank you.
Yeah, okay. Thank you. So as I mentioned before, item 11 and item 12, we'll have to note those ones not to receive because unfortunately Caroline is unable to be with us. I don't know whether any exec colleagues have got anything they want to particularly pick up or pick out of those items. But if not, then what we'll do is move on from the assurance bit into finance. Phil, did you want to come in on anything?
Yeah, just to say apologies from Caroline. Probably the issue for governing body colleagues to note from a service performance point of view that Caroline would have highlighted is the position across Humber Coast and Vale around number of long waits for elective treatment, particularly polarised position in the Humber, but equally within York Foundation Trust, there are a number of long waits, and as we go into this next wave, we are very focused on what we can do to make sure that those patients are able to access their treatment and surgery. So I think we should just note that as an issue that we'll continue to focus on and report back on, Nigel, in due course. And of course, it's a moving position because of the rapidly escalating position in terms of demand on beds in York Hospital, but equally in Scarborough, which could impact on York as well.
Yeah, thank you very much. Okay, so what we'll do then is move on to finance bit of the agenda. So that's over to Simon.
Thanks, Nigel. The report's there for questions and by way of information. I guess consistent with previous months, what we're reporting for month 6 and our forecast position for the rest of the year is break even. That's after significant non-recurrent funds have been received from NHS England and Improvement in support of the unique situation this year. Worth scaling those supports. We started this year with a recurrent underlying deficit of £24 million. It's probably in the region of £26–27 million now. So effectively, we've increased the recurrent expenditure of the system in responding to the situation. So in forecasting that we'll be break even by the end of the year, that's the level of non-recurrent funding we're in receipt of, so circa £26–27 million. That's a combination of response to COVID, but also underlying variances from budget that are being brought back to break even by central funding. Looking forward to 21-22, this is not a scientific forecast. However, the received wisdom in local finance communities is we would not expect to move back to our prior funding regime in 21-22. In other words, we'd expect, and this is broadly the communications we're receiving, we would expect some continuation in some form of this year's arrangement. So some continuation of block contract values being based on the cost of current provision, supplemented by the response to COVID. That said, we continue to maintain our approach to scrutinising and having a grip on our level of expenditure. So looking forward to the next few months, we still have not had confirmation of our month 6 funding. So our anticipation is that we'll be trued back up to break even for both variance from underlying budget and COVID expenditure. That's certainly happened up to month 5. We're not expecting to have confirmation of that until early December, as the national team continue to scrutinise the month 6 position. Looking slightly further than that, we've got 3 broad areas of risk that we're managing beyond our normal underlying risk. So prescribing costs would be one of those underlying risks. But on top of that, we've got a situation that we're involved with managing, which is threefold. The first, independent sector elective activity and associated funding. So as part of the elective waiting list recovery programme, where registered providers are able to offer additional support to managing waits that have increased over the last 6 months, those costs will be funded centrally. Where we are locally able through CCG held contracts to support that, that funding will also be made available. Registered providers or where providers are available but they're not registered, so in the sense of our local orthopaedic capacity, so NIOS, ECOS as providers, they're not in and of themselves recognised as organisations. They can provide weekend and evening work, but we are still awaiting clarity as to whether that will be funded. Work is progressing in that regard on orthopaedics, and that to some extent is at risk. We've agreed across the 4 major NHS organisations in York and North Yorkshire that we'll proceed in that way, but we've yet to have confirmation that that will be funded. So that is something we need to keep a close eye on. We are slightly more confident, or a reasonable degree more confident about outsourced activity in ophthalmology and endoscopy, because those are recognised providers. So that continues to be something we're looking at. The other aspect of risk that still continues to be a focus is the hospital discharge programme, phase 2. Likely to be cash limited, whereas the first phase in the first 6 months of the year wasn't. We are working closely with City of York Council to understand what costs we're predicting for the rest of the year, prioritising placements, but there are some staffing implications being put in place as we speak around community services to get us safely through winter. We've got a reasonable grip on those, I think. And then there's the broad COVID costs. Most of the COVID support has now ceased. So we're back to either a position where providers are able to access centralised resources for that. We're not really expecting any novel reclaims for COVID costs specifically in the last 6 months of the year. However, there is also the as yet unknown risk of what happens as we've progressed to phase or to stage 4 of the national risk programme. We don't know what's going to happen with this current phase of lockdown and the current trajectory of the illness. Therefore, we've got to be live to the fact that all of these things might change. I suppose the last thing I'd want to raise with governing body is we've spent quite a lot of time over the last 2 years instituting what I would describe as GRIP in this organisation, but also in wider aspects across the system. There was an unhelpful attitude, I would describe, across the system of, well, we just overspend and somebody finds the money from somewhere and we cost generally more than we get. So that's just how it's been. And we've spent quite a lot of time and effort recalibrating that belief system to one of, we are responsible for the position and we will deliver the services at an appropriate quality and at appropriate performance levels within the budget we've got. Clearly, the budget we've got has substantially changed over the last 6 months and will probably change over the next 6 months and the following 12 months. That has a behavioural impact. What we've spent our time doing over the last 2 years is changing the system behaviours and attitudes. And I think to good effect. Last year, the CCG broke even for the first time since 14-15. It is just a source of nervousness to me that the continued allocation of centralised money inevitably and understandably diminishes that level of grip and focus on finance. So that's just something I thought I'd mention. It's not something I've got any specific concerns about. It's more of a generalised concern, but it is something that I think we ought to be conscious of as a governing body. Inevitably, when much more money is coming into a system, as I said at the start, that's in the order of 26 million pounds for this organisation alone. It is very easy to get reliant on that level of funding, and there's no sense in the long term that that's going to be sustainable. So a continued focus on grip is something I thought I'd just raise as a theme. Again, no specific concerns, more of a generalised issue for us to think about.
Great, thank you very much. David, I don't know whether your IT is working. I know your iPhone's on the call, so maybe that's going to work for you.
Can anybody hear me?
Yes.
Wow. Well, that's amazing. What I've done, I don't know, but there we go. Fine, yeah. No, I mean, I think Simon's absolutely right. I mean, what we've tried to do as a group in finance and performance is to maintain a view that the services that we've all strived very hard to achieve over the last couple of years, we're now going to have to go to kind of other people within the system to be paymaster, but we must keep our integrity and I think, particularly in these changing times, I think the role of the committee is to try and hold a steady kind of steady state. Really, we've got to look to the future. Things have got to change. We want to be at the forefront of that. But I think, as Simon rightly says, we've got to keep a grip on what's happening, and our stance with our our brothers and sisters in other parts of the system. We've got to be really sure that we're protecting services for the Vale of York, and we'll continue to do that.
Yeah, thanks, David. So, Simon, is there anything that we could do as governing body around the grip, around that aspect of it? What support can we give with yourself and David at F&P?
I think it's just keeping a focus on the medium to longer term, and we've got a range of improvement and transformation programs that remain relevant and remain the right things to do. So referral for expert input, how we coordinate the activities of independent sector and NHS providers in response to elective demand. It's really just keeping finance present in our consciousness when, with all of the best intentions in place. That is not people's prime focus. People are just focused on getting through the next 6 months, and understandably and rightly so. I guess it's our role as the system funder to make sure that people don't lose sight of the fact that at some point in the future, we will have to come back to a fixed resource that is somehow based on the needs of our population or those assessed needs, and therefore that the good things that we thought we ought to do, things like referral for expert input, those things need to still happen and need to be resourced. So it's in some ways an unreasonable request, whilst everybody's incredibly busy and incredibly focused on the here and now. It's to some extent a bit of an unreasonable request that we keep focused on the good stuff that we were minded to support and do 6 months ago.
Yeah. Could I just add, Nigel, that at this moment we're actually making a net contribution to the system. So that's it's a really significant thing for the Vale of York to be doing. There's still the major underlying position, as Simon keeps reminding us, and we do still have some serious financial challenges, but nevertheless we are net contributors to the system working, which is a real change from years gone by when everybody was just fighting their own corner and not willing to contribute. So I think there is the beginning of a change. The wind of change is blowing through.
Yeah, great, thank you. Chris, did you want to come in, and then Michelle?
Yeah, well, first thing I wanted to say was I just think it's really commendable the last 12, 18 months, the position financially we've come from and to. So that's really, really positive. What keeps coming up is pre-COVID is the prescribing is always a challenge. And I've raised this before, but I just want to understand that really and see what we can do about that, because if we look across Humber Coast and Vale, our prescribing is really good. We're really cost effective. Where meds per patient is low. So just trying to understand why it always comes up as a deficit position for prescribing and what we can do about it.
Yeah, and therein, Chris, lies the huge challenge that Vale of York had. It was one of the lowest per capita funded CCGs in the country. In the northeastern Yorkshire, it's pretty much bottom of the pile, if that's not an indelicate way of putting it. Our current underlying deficit is circa £26 million. If we had the same pounds per head as Harrogate CCG in its previous guise, we'd have an additional £26 million a year. So we'd be break even. Are the populations so different? I can't see it, but that's what the stats say. So we have some pretty unique challenges. Our challenge is to do the right thing and to be as good as we can be. And I think as long as we can continue to say our prescribing receives more than the input you would expect for such a relatively low level of resource going into it. So the CCG's own medicines optimization team is not big by any stretch of the imagination. We more than punch our way in regards to this, and our prescribing is, as you said, generally very good. It's more about continuing in that regard, and that's really difficult because it feels like a bit of a thankless task, really, because inevitably the budgets are, in an underlying sense, squeezed, and we are clinically doing the very best we can. And when we compare ourselves to peers, we fare very well. So
can I just understand the allocations we give to prescribing? Are they nationally directed, or do we say this is how much we think we will spend on prescribing? Which of the two is it?
It's a combination of the two. So there are nationally. So our funding is set nationally. There are indicative inflation assumptions for all manner of CCG spend, including prescribing. Inevitably, then we need to set a savings ambition. Over the last, if COVID hadn't happened, we'd set ourselves what I would have said was a very realistic challenge. The challenge we set ourselves last year was probably unrealistic and was not delivered. Learning from that, we set ourselves pre-COVID a fairly reasonable challenge into this year. So to have a modest level of spending increase. So probably in the order on the total budget of about an increased spending of £1 million, which required about £1 million of spending in round numbers. So it's but COVID's happened, and effectively any overspend on prescribing in the first 6 months has been supported nationally. in the next 6 months, prescribing continues to be a cost pressure, and we're going to have to find ways to either improve what we're doing or find other sources of funding to offset the pressure on that budget.
Okay, so yeah, so I'm interested in that that conversation then, and you know, any clinical input that might be needed. Say we're good, let's be excellent. Then that's basically what we're saying.
Yeah. No, thank you.
Okay. Anybody got any other things to pick up for Simon? No. Oh, thank you very much, Simon.
Okay.
And we'll move on now in the agenda to the last bit, which is to get a verbal update on COVID-19, and that's Michelle.
Thank you. This is where we'll really miss Andrew's input to this, but I'll give it a good go. And Sharon, I think, is still on the call anyway, if she wants to input. So as of yesterday, we moved into national lockdown, but also the DHSE introduced a letter to everyone late last night saying that the country is moving to national incident level 4, which means that is directly related to the pressures in the acute trusts that are really swelling, and you'll have seen and heard some of that. And locally, our system is also experiencing increased demands from COVID patients or those presenting with symptoms. And what that national incident level 4 means is that nationally they will take some decisions for us, and not just necessarily leaving it to local. That might include stopping some activity. We wait to see what that means. So that's where we sort of are nationally. I mentioned the change to the visiting guidance for care homes and also for hospitals. That's being worked through. The discharge guidance that came out to support COVID, that changed more recently, has required us to set a series of processes up and people in post as sort of discharge coordinators and system conveners on behalf of North Yorkshire and York, which will hopefully expedite discharges, but hopefully in a safe way. It's reliant on people fitting into particular pathways, and the difficulty we have been battling with directly related to COVID is those patients who are COVID positive, still within the seemingly infectious period of 14 days, who are ready to be discharged, and where should they go? And people in this system will know we've had Peppermill Court as a residential facility for quite some time. We reopened that a few weeks ago. It's just starting to get some admissions in there, but they're for patients with residential needs. And we have looked at all the opportunities available to us for nursing beds for COVID positive people still within that infectious period, and haven't been able to identify any in the York area. So at this moment in time, we are going for a North Yorkshire and York system response by commissioning beds in Scarborough in one particular nursing home to do that. In order to discharge people to those beds during their infectious period, we have to announce that they are designated COVID beds to the CQC, and we had to do a return, I think it was yesterday by 4 o'clock nationally, about what beds we had available. And you can only discharge people in their infectious period back to those designated beds. We have raised, as a system, a number of queries to the CQC on this, because we believe that as long as the nursing home could demonstrate that they were able to isolate people and it was a COVID secure environment, that those people admitted with COVID-19, ready to be discharged within 14 days, our preference would be to find a way that they go back to their own home rather than to a designated bed and then back to nursing home. And also the same relates to end of life. It doesn't seem, morally right, but there needs to be teased out some better and more straightforward guidance from the CQC on this, because it remains a little bit unclear. So we're battling with that. And then the other pathway that we're battling with is those that test negative for COVID, but are being treated as COVID positive because people are clinically convinced that they have got that, but they're testing negative. And if they're ready to be discharged within that 14-day period, where do they go? And you could say, well, we're treating them as COVID positive, they should go to those designated beds. But ethically, if they don't have it and we're knowingly putting them into a COVID positive environment, that's something that we need to grapple with and agree as a system what we're going to do with these individuals. So there's some knotty issues there. Contact tracing, particularly for primary care, the CCG is supporting people with, and there's been some learning that I described before around some of those outbreaks or positive cases within primary care, but I hope that people are finding that helpful. More recently, as in the last few days, the guidance has been strengthened around extended use of face masks. So we're getting that out to primary care because the use of a fluent repellent mask is not a get out of jail card free in terms of contact tracing. It is based on risk assessment that we will help people with when they let us know if they've had positive members of staff. And it becomes much more important around social distancing, much more important. But we're happy to help primary care answer any of those queries if they get any positive staff. Testing continues to be interesting. Now that some people might have heard that nationally there is a move to regularly test all staff, particularly in the acute trusts, whether they're symptomatic or not, on a very regular basis, that will cause particular pressure on Pillar 1 testing, and they're finding ways to try and do that whilst also testing symptomatic patients and staff and providing opportunities for other people in the NHS to use that service, such as primary care. Pillar 2, there were significant national issues. Those are pictures looking much better. People are accessing Pillar 2 easier than they did. We've increased the availability of testing within the York area that particularly started for university students. Flu, we've talked about. The vaccine, there are significant pressures on systems to be ready with some plans by the 1st of December, even if we don't have a vaccine available by then, as to how we would attempt to do mass vaccination. The SRO for York as a place is Sharon Stoltz, who's on the call, supported by myself in the CCG, and things are increasing in terms of the conversations and the meetings around how we might set ourselves up as a system to deliver a mass vaccination programme for COVID. There is money that will come with it. We don't have the details of that yet. And so, we are going to need a lot of partner support. The first priority for the vaccine, when and if we get it, is for the cohort 1, which are over 80s, and also for frontline NHS staff. So I'll stop there in terms of COVID update. If anybody wants to ask me anything, or Sharon to come in. Oh, here she is. I'm happy to come in.
Great. Sharon, do you want to do an update for us, and then we'll go to Andrew?
Yes, thank you. Just to add a little bit of information to what Michelle has already updated. And so I'm less familiar with the figures for North Yorkshire, so apologies to those covering the county. But certainly in City of York, colleagues will be aware that we saw a significant spike in cases in September. And as a council, we were put into Tier 2 or higher restrictions. Since then, in response to a lot of the work that was done in response to that, I'm pleased to say that our rates have fallen back quite significantly, and we have enough data now to be sure that this is a sustained downward trend. So our 7-day rate for York at the moment is 186 cases of COVID per 100,000 population. That's lower than the regional and national averages. And also our positivity rate has fallen. That was around 18% about 3 weeks ago. That's now fallen to 11.6%. Which is lower than the regional rate and very similar to the national rate. So that's very positive. We've seen a decrease in cases across all age groups, but the largest drop has been in 18 to 30-year-olds, which reflects all of the work that as a city we've done to and with the universities to support students. In terms of outbreaks, we have 3 care homes at the moment with cases within the City of York Council boundary and 5 schools. I'm aware that North Yorkshire has had more outbreaks than that, but small numbers and well controlled in York. Members of the board will probably be aware that we now have our own local contact tracing service in York, which is complementing the national one. That's going incredibly well. We're reaching over 80% of contacts referred to us by the national test and trace programme. And I'm aware that North Yorkshire is going live with their local contact tracing service next week, I believe. In terms of testing, we are exploring options at the moment around testing. We have the drive-through site at Poppleton Bar. We have a walk-in site on the university campus. North Yorkshire has been working with Department of Health and Social Care and Deloitte to extend their access to walk-in testing facilities, and this is something that we're exploring in York, but we're also exploring whether we will pilot some of the new rapid testing that's coming online. The so-called LAMP testing or lateral flow tests. So that's something that we're exploring at the moment, because as Michelle has already indicated, it's important that we have sufficient access to COVID testing for our staff as well as residents. In terms of Pillar 1 and Pillar 2 nationally, the DHSC are tending to merge those two now and not have the same distinctions between Pillar 1 and Pillar 2. I think there are some advantages to that because it gives us more flexibility in terms of access to local testing. So generally, a positive picture for York, but obviously we need to keep up our sustained efforts. We are still, as Michelle has said, seeing activity within the hospital. The hope is that as the prevalence of COVID goes down in the population, then we'll start to see hospital activity around COVID fall as well. But it's too early to know whether that's going to happen. But hopefully, because of the time delay, we will actually see a reduction in hospital activity. And we're seeing very low numbers of COVID-related deaths at the moment. I think we've had about 3 so far amongst York residents, so much lower numbers than we were seeing in the spring. So a quick overview, and I'm happy to take any questions.
Great, thank you very much, Sharon, and that's great about the local contacting system. Anybody got any things they want to pick up? Andrew?
Yeah, sorry, it's just a quick question. I just wondered, you might not be able to answer this yet, but in terms of the first cohort for the COVID vaccine, is that likely to include all frontline primary care staff, or are we talking clinical staff, or are we talking different types of clinical staff, or do we just not know yet?
I think we don't know yet. I think Sharon went to the first North Yorkshire and York conversation about COVID vaccine, and there is a lot that we don't know yet. There was talk of the cohort firstly being over 80s and NHS frontline staff, what that actually means in practice is another thing. And I think, you know, will come down to a number of factors.
Okay, thank you.
Great. Thank you very much. Any other comments or questions for Michelle or Sharon? No. Great. Thank you very much, both. So moving just to check the agenda, I think that concludes the items that we need to go through today. We noted the received items, and our next meeting will be on the 7th of January next year in public. So just want to say finally, thank you very much to all the exec team, all the CCG team, but also everybody who's working very hard in all sectors of health and care at the minute. And to public members that are watching, we just want to say keep safe and keep doing the national guidelines on what we need to do at this time. And we'll see you back probably on YouTube on the 7th of January. So